Hi, good afternoon, everybody. I'd like to thank the organizers of the show for inviting me to talk to you and take you through the journey of knowing your fertility potential from egg counting up to your IVF if you need it. My name is Amin Gorgy. I'm a director of the Fertility Gynaecology Academy, and that's where I'm based, at the corner between Wimpole Street and New Cavendish, at the Fertility and Gynaecology Academy. What I'm going to talk to you today is going through the journey from starting from improving your chances of natural pregnancy to how to check your fertility potential and tips to improve your treatment outcome if you need treatment, then causes of IVF failure and recurrent miscarriage. And we will also talk about cumulative egg freezing and embryo freezing, and at the end we'll talk about egg donation and egg sharing. Now, there are tips that you can do to improve your chance of natural pregnancy or natural conception. It's all about really lifestyle. It's good to have regular sex, and particularly about the time of ovulation and about the mid-cycle time. Having intercourse 2 or 3 times a week is good. For women, body weight is important to keep it between 19 and 25. And there's evidence in the literature that if you are overweight, your chances of natural conceptions is reduced, and if you're underweight, it's the same. It's better to stay away from chemicals, like printing chemicals or pesticides that can reduce your chance of achieving natural pregnancy. Moderate exercise is important. Don't overdo it. And people who do housework or moderate exercise, they have far better chance of achieving natural pregnancy. Reduce your stress with enough sleep, and again, reasonable exercise will help improve your chances. Drink water. Water is important for the body function, including the mucus, the seminal fluid, and everything in our body. Do not use douche. This is not normal, and it can upset the pH and the normal flora in the vagina. Be careful with the slippery stuff, because many of them actually do adversely affect the sperm. Always stick to the oil-based one that would help the sperm. Obviously, we all know reducing alcohol, drugs, and I would say away from the drugs, and reducing caffeine would help. For men, again, regular sex, body weight watching, away from the pesticides and the chemicals, drinking water. Scrotal temperature is important, and we noticed many young men have the laptops in their laps for a long time. That's not good. Electromagnetic radiation from mobile phones. So we advise young men who are trying to start a family not to keep their mobile phones in their pockets or by their belts, because there is evidence that this electromagnetic radiation can affect the sperm motility and what we call sperm DNA fragmentation. And there is quite an association between high DNA fragmentation in the sperm and failure of implantation and miscarriage. Again, alcohol, drugs, and caffeine reduce as much as possible. This slide tells us about the relation between age and infertility and when to start seeking medical advice. And this recommendation comes from the CDC in America. If you are under 34 and you have 1 year of regular unprotected sex to become pregnant without success, you need to seek medical advice. If you are 35 to 38, after 6 months, you should start seeking medical advice. After 39, 3 months, if there is no reason for infertility, you should seek medical advice. And on the right side of the slide, you can see that the infertility risk by the age of 30 is about 7%. This increased to 11% by the age of 35, up to 33% by the age of 40, and up to 87% by the age of 45. So the older you get, the sooner you should seek medical advice if you can't achieve natural pregnancy. Now, what is the fertility potential? The fertility potential of women depends on 2 main factors: age and ovarian reserve. The fertility potential decreases with age, as probably most of us know, because with age, the number of the growing follicles, or what we call pre-antral follicles, is reduced. And age predicts mainly the quality of the eggs rather than the number. So the older we get, the less of good quality the eggs would be. The second more important factor is ovarian reserve, and that represents the number of recruitable follicles in the ovaries, that the number of the follicles that are ready to grow. It predicts the response to ovarian stimulation and IVF or any sort of fertility treatment. So the lower the ovarian reserve, the higher the dose of drugs you need. It predicts quantity or number of the eggs rather than the quality. Remember, the quality relies more on the age. And ovarian reserve can be determined by two factors or two tests, AMH and antral follicle count. AMH is anti-mullerian hormone. It's a hormone in the body that can reflect the ovarian reserve or the storage of the ovaries in your, the storage of the eggs in your ovaries. And obviously, as we said, it decreases by age. So by the age of 25, the median AMH level, acceptable levels as a median, is 24. Better to be toward the 33, because this reflects about the 75th centile. At the age of 30, we expect something between 17.5 and 28. 35, 10 median, 28, 21 the good level, 40, 5 to 11. By the age of 45, the AMH is expected to be as low as between 2.5 as a median level and 7.5 as a good level for that age. Now, the antral follicle count is checked by vaginal scan. We count the small follicles in the ovaries, in both ovaries. The ovaries between 2 and 6 millimeters are more relevant. Between 7 and 10 are less. Basically, it tells us about the reserve in your ovaries. And if we do count the antral follicles in both ovaries, if they are less than 4, we expect very poor ovarian reserve. Between 4 and 7, poor ovarian reserve, you need high dose of stimulation. 8 to 12 is still reduced reserve. 12 is the minimum number for normal reserve. We'd like to see it much more than 12 if possible. Now, this slide tells us about the biological clock. And if you can see here, at the age of 13, when girls start having periods and puberty, they have about 350,000 eggs in their ovaries. By the age of 25, this goes down to 130,000. And the monthly live birth starts to decline a little bit from that age. So by the age of 30, you have 70,000 eggs, and that's 12% of the eggs of the original count remaining in your ovaries. By the age of 35, this goes down to 30,000, 40, 13,000, 45, 40 is 13,000, 45 is 5,000, and this reflects 1% monthly chance of live birth. At the age of 51, when you have no chance and you're really approaching menopause or you're already menopausal, you still have 1,000 eggs, but these eggs are of very low quality and unlikely to give you any luck. To check the potential, the fertility potential, we need to check the tubes as well, and this slide reflects the uterus and the fallopian tubes. And basically, we put a catheter through the neck of the womb, inflate a balloon to maintain the catheter in, and we inject either saline or air or dye material, whatever the method is, to tell us about the tubes and to make sure that the tubes are open. Because if the tubes are blocked, there is no chance that the sperm and the egg will meet. Now, this is about semen analysis, and the parameters, the normal parameters or the parameters of the normal sperm have been changing, and the last parameter determined by the World Health Organization was 2010. And as you can see from this table, we expect the volume to be 1.5 or more milliliter, the pH 7.2, sperm concentration 15 million per milliliter or more, total sperm count 39 million or more. Very important, the motility should be more than 40%, and progressive motility 32% or more. because if the sperm is not moving enough, it's not likely to have the energy or the power to fertilize the eggs. Vitality is very good, is very important, and has to be 50% or more. And morphology is a very important parameter in the sperm assessment, and up to 96% abnormal is accepted as within normal. So we're looking only for about 4% or more to be looking normal. Now, all these are the minimal parameters. And normally when we look at the semen assessment, we take all the parameters together to assess the ability of that sperm to fertilize the egg naturally. So these are the minimal parameters, but we'd like to look at the whole thing as together, rather than sticking to one parameter and say that's it. How to improve the fertility treatment outcome? So hopefully you do not need fertility treatment, but if you need fertility treatment, how can we get this work best for you? First of all, we need to determine what's best treatment for you. Ovarian induction or ovulation induction, where we induce ovulation in the ovaries if you're not ovulating regularly, or you have 46 ovaries and you're not ovulating regularly, probably just simple treatment to make you ovulate will be the answer. IUI is intrauterine insemination, which is similar to ovulation induction, but we get the semen sample, we prepare it, we choose the best, concentrated in a small volume, injected high up in the womb at the time of ovulation. You might need IVF, where we mix the sperm and the eggs outside, or even IVF ICSI, in which we inject the sperm into the egg, what we call intracytoplasmic sperm injection. Number two, selection of the protocol. We'd like to select the best protocol that suits your circumstances, your body. Drug selection, do we give you FSH only, or FSH and LH, which is called HMG? Should we give you standard dose, mild stimulation, or give you natural cycle? Should we add extra lab procedures to improve the outcome, like assisted hatching or blastocyst transfer? Should we include other clinical and lab procedures to improve the outcome? As I said, ovulation induction is giving you a small dose of drugs to produce a couple of eggs. Obviously, the picture here is from IVF, and when you have ovulation induction or intrauterine insemination, we'd like you to produce 2 or 3 eggs only. More than that, either we have to convert it to IVF or cancel the cycle. IVF, the picture below, where we mix the eggs with the sperm in the lab, and hopefully natural fertilization will happen. Intracytoplasmic sperm injection, or ICSI, where we inject 1 sperm into each egg. Some other surgical procedures might be needed to retrieve the sperm in males who cannot produce sperm outside. If there is obstruction, we can retrieve the sperm from the epididymis, which is the structure next to the testicle, with a needle, as the picture shows. Or if it's a problem of producing the sperm from the testicle, we can go with the needle in the testicle and aspirate the sperm from there. Do you need mild or standard or natural IVF? Natural IVF is far less successful. It's only 1 follicle. And if you are not ovulating regularly, there might be no egg there, or the follicle might be empty. There is no enough evidence to support mild IVF to be superior or even as good as normal stimulation. But some patients will produce the same number of eggs, whether we give them high dose or mild dose, because that's what their ovaries can provide anyway. So in this particular group, we can go for the mild dose because there is no extra benefit by giving the high dose. It's claimed that with mild stimulation, you might have less % of abnormal embryos. This has to still to be shown. And in terms of absolute number, it's not really realistic. You might have less percentage of abnormal chromosomes, abnormal embryos, but in the absolute figure, you have more embryos of normal chromosomes if you give the standard dose. Other techniques to improve the outcome in terms of implantation: assisted hatching, where we make a breach in the shell of the embryo, what we call the zona pellucida, and this has been shown to improve the embryo to hatch out and implant. It has been done mechanically or by chemical means, but the best way and most precise and the safest way for the embryos is using the laser technique, because you use the laser beam to make a very small, precise hole. There's a Cochrane review in 2006 and showed increased clinical pregnancy following assisted hatching, particularly in patients who are 35 and above. The other thing to choose the best embryos is blastocyst transfer, where we keep the embryos in the culture medium in the incubator and put them back only day 5. Obviously, there's a selection process here because some embryos will stop halfway through and you are waiting until you choose the best embryos. So if you have a good number of embryos and wait longer, we can choose the best. But if you put the best embryo on day 3 or day 5, it will do the same job. But if you have 5 embryos and want to put one only, you might be better waiting for day 5, so make sure that the one we're putting back is really strong enough to keep going. Simple tips to improve the outcome, like endometrial scratch. We do nowadays scratch the endometrium the month before the treatment, and this has been shown to improve the implantation. And the idea that scratch is a damage, and when you damage the endometrium, it attracts the stem cells from the blood passing by, and these stem cells make the endometrium better the following month. Mock embryo transfer, in which we measure the length of the cavity of the womb using a hysterometer or whatever method. And this will give us an idea how long the cavity is. So when we put the embryos, we make sure we put them about 2 centimeters or 1.5 centimeters below the top of the uterus, because this has been shown to give the best chance of implantation. So you do the scan, which is the next one. You do the embryo transfer under scan guide, and you know the length of the cavity. So you make sure you put the embryos at the best time to give them the best chance to implant. Time-lapse imaging or embryoscope. This is basically a closed incubator with a camera inside, which takes a picture of the embryos every 10 to 20 minutes. So you don't have to take the embryos out every day to check them, and you can go back and run the picture or the video back to see what happened when you were not watching. So that will help you to choose the best embryo, the embryo that's going consistently at a steady speed. Because sometimes embryos go fast and slow, and obviously the embryo that's going at steady speed is the best one to implant. So it benefits 2 factors. One of them, you choose the embryos by knowing what happened when you were not there. Number 2, you don't take them out. So you leave them in a consistent environment and safe environment. But some patients still have repeated IVF failure, and some would have repeated miscarriage in spite of getting pregnant every time. What could be the reason for that? I'd like to summarize the reason in about 5 categories. Number 1, chromosomes. Sometimes we have what we call translocation, where a piece of chromosome jumps in another. It doesn't reflect in our physique because the complement is maintained. So we look normal, we have no problem whatsoever. But when the cell divides to form the sperm with the egg, that balance might be lost. And then the embryos have the problem of not implanting or implanting and get detached in terms of miscarriage. So we'd like to check the chromosomes. It's not a major factor. Only 3 to 5% of patients will have this problem. The cavity of the womb, obviously if there's a problem with the cavity, whether it's congenital or acquired, can affect the chance of the embryos implanting or the pregnancy continuing. And we do check the cavity of the womb with aquascan, as I explained before, which can be called saline installation sonography or saline hysterography. No matter what the name is, they're all the same. Basically, you inject saline, which is sterile salted water, inside the cavity, distend the cavity, and look if there is any polyp or adhesions or septum. Hysteroscopy is another way of checking the cavity. Infection screening, we'd like to do vaginal swab, semen culture and sensitivity, and we check the blood that comes in the period, the menstrual blood, for 25 microorganisms by doing PCR for the DNA of the microorganisms. The last test we'd like to do is sperm DNA fragmentation, where we check the DNA in the head of the sperm for immaturity or breaking down. We used to believe that the sperm is a fertilizing agent, and once it fertilizes the eggs, it's not important anymore. Unfortunately, that was wrong. And the DNA of the sperm contribute to 50% of the DNA of the embryo. So it's as much important as the egg. And that's why we'd like to check the DNA in the head of the sperm. These two pictures show us what the aqueous can show. On the right picture, you can see there is a septum, which obviously we can do hysteroscopy and cut through it and remove it. The second one will show this little couple of polyps, which obviously can work as a coil, preventing implantation or can cause miscarriage. So we need to do hysteroscopy and get rid of them. If the sperm has immaturity of the DNA or breaking down, there are two techniques to select the best sperm in the ejaculate. One is called MC, intracytoplasmic morphologically selected sperm injection, in which you magnify the sperm to 6,000 instead of 400 times, and that will give you a chance to see sperm with vacuolations, abnormality, and all sorts of problems. And this will help you to choose the best sperm that's looking normal at 6,000 magnification and inject it into the egg. The other one is called the PIXI, which is pre-selective intracytoplasmic sperm injection. Basically, we put a drop of hyaluronate on a slide and mix the sperm with that drop. Hyaluronate is the material in the shell of the egg that attracts the sperm. So the sperm that moves toward the drop or attached to the drop, that the sperm that had mature acrosome and mature DNA, because it knows where to go. The sperm that's moving away, even if it looks good, is probably useless sperm because it doesn't know where to go. So we pick the sperm that's moving to the hyaluronate or attached to the hyaluronate and use it to inject the eggs. Big group of factors or causes of repeated IVF failure and miscarriage is immune system imbalance. We know that the baby is at least half foreign to the mother's body, and that's not normal for our body to accept foreign bodies inside. So the immune system works in a very special way to accommodate that half foreign body for 9 months. And there are tests to check to see whether the immune system is well balanced and reacting in a proper way to accommodate the pregnancy or not. One of them checking for antibodies, anti-nuclear antibodies, anti-histone antibodies, anti-thyroid antibodies, double-strand DNA antibodies. There are a group of antibodies that can check that are more relevant. We check you for natural killer cell activity in the blood and the endometrium. We check you for something called Th1, Th2 intracellular cytokine ratio. This is a ratio between two groups of chemicals in the body. A group which is Th2, they calm down the immune system to accept the pregnancy, and they're very important. And actually during pregnancy, they take over and they increase. The other group, which is Th1, defensive antibodies, defensive cytokines, which make your body defend itself against bacteria, virus, and cancer cells. But if it goes over the top, it puts your body in the defensive status, and that's not good for the embryos. It makes the environment not friendly for the embryos or the pregnancy. The other test is thrombophilia, which is blood clotting mechanisms, and they are closely related to the immunology, and they can be implemented in IVF failure and miscarriage. Another test called leukocyte antibody detection, or paternal leukocyte antibodies. These are antibodies that your body will produce to protect the pregnancy. Because remember, the placenta has antigens from the father that's foreign to your body, and the function or the job of these antibodies is to cover these foreign proteins and make your body feel that the whole pregnancy is yours, so you don't reject it. And we can check the level of these antibodies. The last test is killer cell immunoglobulin-like receptors. These are receptors on the surface of the natural killer cells. We look specifically for 3 of them. If they are missing, you might benefit from a drug called the Neupogen to compensate for the missing function. This is a simple diagram for antibodies, and actually this diagram talks about thyroid antibodies. And we know if you have thyroid antibodies, you have increased risk of miscarriage. And it doesn't sound logic. Why thyroid antibodies make you miscarry? But basically, any antibody in your body that's not supposed to be there indicate that your immune system is overactive. And actually, these antibodies affect the placental cells and increase a cycle of apoptosis. And apoptosis means death. So the death cycle of the placental cells goes high, and that affects the placenta, make it less efficient. And actually, the antibodies increase the inflammatory reaction at the feto-maternal interface. So at the placenta, where the mother meets the baby, it becomes inflamed and not good to keep the pregnancy. Before implantation, if we have antibodies, and particularly a material called TNF-alpha, which is one of the Th1 cytokines, that makes the environment not friendly to the embryos and can actually affect the embryos and can make the embryos not grow properly and unable to implant. And even after pregnancy, this can cause the baby to grow very slow, reduce the amount of the amniotic fluid, and actually cause bleeding under the placenta, which will end up with miscarriage. And actually, immune imbalance can be responsible for many problems during pregnancy, from failure of implantation to miscarriage, to small for-date babies, premature labor, premature rupture of membranes, preeclampsia, and placental abruption. All these have been shown to be due to immune system imbalance. If you have immune system imbalance, after doing the test, obviously, we can offer you immune supportive therapy, and it depends on what you have. We can give you aspirin, steroids like prednisolone, Clexane, which is a blood-thinning drug, intralipids, which is soya beans and egg yolk, but they were found to reduce the NK cell activity, natural killer cell activity. Intravenous immunoglobulin, they do the same, but on a wider and a stronger range. Lymphocyte immune therapy, which will make you produce the antibodies that protect the pregnancy. A drug called GCSF or Neupogen, that if you're missing the killer cell immunoglobulin-like receptors, and hydroxychloroquine, which is a very well-known anti-malarial drug, but has been found to help a lot with the immune system. And actually, it's a very safe drug to take even during pregnancy. We move from then to what we call cumulative egg and embryo freezing. If you are not ready to have a family yet, or you don't have a partner, or you want to postpone starting a family for educational reasons or financial reasons or whatever reasons, you can freeze your eggs and keep them as an insurance policy for the future. The same stimulation process like IVF, but when you collect the eggs, we don't fertilize them and freeze them. Now, if you are in an established relationship or you're married, but not ready to start a family now, to have kids now, you can freeze embryos. You can create embryos with your partner or your husband and freeze them, because you don't want to leave it until you are 38 and start trying. Maybe it's not suitable for you now to start family, but you want to have kids later on in life, and you're worried about reduced ovarian reserve and difficulty in conceiving. Vitrification made egg freezing and embryo freezing far better than before. The egg actually was one of the most difficult cells to freeze, because the egg is one of the biggest cells in the body. It's 150 micron in diameter. And the freezing with the old slow method made the inside turn into crystals, ice crystals, and ice crystals would damage the inside of the eggs. So that was the results of egg freezing using the old method, were really not very good. Now we're using what we call vitrification, with the snap freezing or fast freezing. And instead of changing the inside into ice crystals, we change the inside into like ground glass. So that doesn't damage the egg inside. And the survival rate on freezing and thawing is about 90%. And the success rate using frozen eggs with ICSI, implantation as good as fresh, live birth is nearly as good as fresh. The last resort, if you cannot produce your own eggs for whatever reason, either because of your age or some girls unfortunately have very low ovarian reserve early in life, in their late 20s or 30s. They cannot produce enough eggs to have a baby. Egg donation will be the answer. It's a different biological solution. And from this diagram, you notice that if you use your own eggs, the chance of having a live birth and cycle goes down, particularly after the age of 40. While if you have egg donation, which is the top diagram, you carry on having almost the same result, because the success rate depends very much on the age of the egg itself. So if you have an egg from a younger woman, you stand a chance of a young woman of success. So to summarize, your fertility potential will depend mainly on your age and your ovarian reserve. Fertility check includes fertility potential, plus tubal check and semen analysis. You can increase your chance of natural pregnancy by modifying your lifestyle, both for girls and boys. You can improve your fertility outcome by adding extra techniques to improve implantation, like hatching, blood test transfer, which will give you a chance to choose the best ongoing embryos. Other techniques to improve the outcome, like endometrial scratch, mock embryo transfer, ultrasound-guided embryo transfer, and time-lapse imaging. If this doesn't work, you can look into the reasons for recurrent IVF failure, including chromosomal studies or karyotyping, checking the cavity of the womb, infection screening thoroughly and in depth, checking the sperm and DNA fragmentation, and checking your immune system, and make sure that it's not working against you. Egg freezing and embryo freezing are options for people who want to have like an insurance policy but not ready to start their family yet. Egg donation and egg sharing if you cannot produce your own eggs. Thank you very much, and if you have any questions, I'm happy to have them now, or later I'll be by the stand of the Fertility Academy until the end of the day. Thank you.
Does anyone have any questions?
Hi. For women who have known medical issues who can affect fertility, like, for instance, one working ovary, would you say it's still worth trying to conceive naturally or go down the route of seeking medical help straight away?
So I didn't hear the last part of it, sorry.
Sorry?
You said...
would you say it's worth trying to conceive naturally or going and seeking medical help?
I would say have your fertility checked. Have your ovarian reserve checked. Make sure your tubes are open. Make sure that the sperm is good. And then based on that, as I said, we don't look at one factor on its own. We put things together and have a picture. And we can say, well, really still, again, it depends on how long I've been trying, and if there's history in the family or personal history of amenorrhea, for example, or your mother had early menopause, for example. And put all these things together and we say one of three things or two or three things. You can try naturally, but get on with it now. Don't wait. Or really, there is factors that you need to have a bit more proactive procedure now, like have, for example, IOI, a couple of times within 2 or 3 months. If it doesn't work, go for IVF straight away. Or go for IVF straight away, because putting this together, your chance of having natural pregnancy is not great. So it depends on the findings together. And putting things together will give you a far clearer picture where to go.
Would anyone else like to ask a question?
I just want to know the process of the actual process of egg freezing. Yeah, how is that carried out? And is it? I know there's injections involved in order to cultivate more eggs, but is it painful or anything like that? Yes, how invasive is it? Yes.
Well, the start is basically similar to IVF. First of all, we need to know your ovarian reserve. And so we have an idea what protocol and what dose is good for you.
How do you check your ovarian reserve?
Ovarian reserve is checking by AMH, anti-Mullerian hormone, which is a blood test, and anti-follicular count, which is scan, and put them together. I know some places depend on the anti-Mullerian hormone only, some units depend on the anti-follicular count only, and both of them is probably as good, but from my personal experience, it's like a bi-dimensional picture. You can look at one side and say, I guess that's the way, but putting them together will give you a far more clear picture. So based on ovarian reserve, we choose what's the best protocol and what dose you need to take. Obviously, we monitor you during the simulation. No matter what the protocol is, the treatment consists of 2 types of drugs. One to stop your pituitary gland from making you ovulating, because we don't want you to ovulate before we collect the eggs. And the other one to stimulate your ovaries to produce eggs. That's in the form of daily injections. for about 10, 12 days. They're not painful, very small needle, they're taken subcutaneous. You inject yourself basically. We teach you how to inject yourself. During these 10, 12 days, we monitor you with blood tests and scans. Blood tests after 3 days of injection, then a blood test and scan almost every other day. Once the eggs, the follicles are ready, good size, your estrogen level is good, we give you a late night trigger injection and we collect the eggs about 36 hours later. The egg collection will be gathered by vaginal scan with a needle going through the vagina into the ovary to spread the eggs out direct under sedation, so you'll be out, you wouldn't feel anything. Once we get the eggs out in the lab, we leave them for a couple of hours, and then we check them for maturity, and we freeze only the mature eggs. Eggs can be frozen forever if you want. Statutory rights, according to HFA guidelines, 10 years, but you can renew them by consulting your clinic and justifying that if you get rid of them, you have fertility issues or your fertility might be affected. That answer your question? Or?
How expensive is that process? If you wouldn't mind giving us a rough estimate.
Obviously, it's not, I don't think it's sponsored by the NHS anyway, but the prices are different in different clinics. 3,500 for one cycle, and actually we usually offer more than one cycle. We offer 3 cycles at a reduced price of 7,500. So it's not that expensive. It's expensive, but I don't think it's that expensive. If you have 3 cycles, freeze eggs probably enough for hopefully 1 or 2 children, and you keep it as a policy for the future, insurance policy for the future. Statistically speaking, you need about 14, 15 eggs to give you a chance of 1 child. So it depends on your age and how many eggs you produce each time. Maybe 2 cycles will be enough to produce 30 eggs or something, and that's enough for you. If you are older with low ovarian reserve, you need more cycles to reach that number. But it's difficult to say. It's not cheap, but I don't think it's that expensive. It gives you the reassurance that you have a backup. And actually, not many women or some women would have frozen eggs and will not use them, because once they drive a family, maybe you get lucky and have completed their family. And there was a research asking women who froze their eggs, what would you do with the eggs if you don't need them? About 63% said we'd like to donate them for research. 18% donate them to another couple who are unlucky to have eggs. Some said we'd discard them, and about 8% said they don't know, they can't make up their mind. So it's like an insurance policy. You might use it. If you don't use it, you can donate it to somebody else or research.
Thank you.
Thank you very much for an excellent presentation, Dr. Gorgy. So you've told us how to optimize one's chance to have a successful pregnancy with an IVF cycle, with fertility and IVF cycle as well. So do you utilize all these methods when you undertake an IVF cycle at the Fertility Academy?
Well, obviously, the investigation for recurrent IVF failure is not used in the first one. So the first one is basically IVF cycle, but we have the options of assisted hatching, embryoscope, and even something called embryo glue. All these 3 things have been shown to improve the outcome. And I think the option that the patient might opt for even the first cycle. But the other tests like thorough infection screening and immune tests and things, all the things really should be left if the first cycle or 2 are not successful, or if the patient gets pregnant and she lost the pregnancy.
And the endometrial scratching?
Scratching, yes, can be used from the first cycle.
So by using all these methods, endometrial scratching, assisted hatching, plus assist and all that, so what is the success rate for IVF cycles in a patient under the age of 35 at the Fertility Academy?
I think at the age of 35, we can easily looking at about 45% live birth rate per cycle if the patient does not have immune issues or of coming first cycle or second cycle.
And how does that compare with the national average?
Ooh. Sam is not here. The national average, I think the national average is about 30-something, 32 to 35.
Okay, thank you.
Hi, thank you for your talk. You mentioned that there are tests out there that would give a personalised sense of how many years of fertility someone might have before the menopause, and I wondered how common it was for people to kind of look for a personal fertility MOT and a sense of how long they can put off having a child, and what the pros and cons of that approach might be.
I just want to make a point clear. The ovarian reserve or MOT is not to tell you how long you can leave it. I think I'd like patients to look at it from the other side, that we're doing ovarian reserve to see whether we need to get on with it now or we can relax a little bit. I think it's dangerous to say, well, you have good ovarian reserve, go and, don't try for 5 years and they still be safe. I think this is very dangerous. And I don't think that test is even designed for that. I know there are a lot of research going on at the moment to see whether what's the relation between AMH and the number of years before menopause. But remember that you can produce less eggs with low quality between 5 and 15 years before the menopause. So I'd like to look at the test that is telling us whether we need to get on with it now or we can relax. Not advise you to leave it. I think this is a bit dangerous.
But I mean, many women do feel like they have careers going on and they want to have children later than they previously would. Is this something that's possible, or is it not really something that the test can offer?
So you mean a couple who want children but not now?
Yeah.
Well, obviously, if everything is normal, that's fine to leave it now, but you need to keep checking it. But as I said, I'd like to look at the test as to warn us if we need to be on now rather than just relaxing.
Thanks.
How quickly does a woman's fertility change? Say over the age of 35, how often should they be going to check their egg reserve or whatever it might be?
After the age of 35, I think every 1 or 2 years is not unreasonable to check their ovarian reserve. Fertility goes down quicker after the age of 35. So I think if 35 and you want to postpone it, you might get on with freezing eggs or embryos. It depends whether you are single or you are in a relationship, rather than, getting sort of anxious about it and just going every now and then checking it. I think 35, if you want to postpone for a couple of years or 4 or 5 years, for whatever reason, I think it's better to have a backup policy.
And what would you suggest for men, not leaving them out of the equation? Do they need to test, over a certain age, how the quality of their sperm, or is that even a factor?
It's not only men, even specialists believe that the sperm is not that important. It is important. And it's just the difference between the sperm and the egg, that the egg has what we call correction ability. The egg is a marvelous cell. It can correct the sperm if the sperm has defects. The egg can correct the sperm. But still the sperm is important. And the other thing that, although men as well as affected by age, but it's supposed to be 10 years later, so if the women at 35, they start the ovarian reserve or whatever it is, start going down, or fertility potential, the men from the age of 45. So they still have 10 more years before things start going down. But it's important to, if you do the check, there is no point in checking the woman and just leaving the man. It's important to have the full picture, because she might be perfect and the sperm might have a problem.
Does anyone else have a question? Kate, 1 second, I'll bring up the mic. It's just for the video recording.
Hello. So let's say that I did a test and all was okay. How dramatically can it change? So how long would I be able to relax for if all was okay?
There are mathematical models, and one of them, the slide I showed earlier on. But people are different. Some people stay high, 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 and then drop, and some people go steady, and some people drop quickly, and then go drop slower after that. So girls are different. Human beings are different. But I think if we take a landmark like 30, 35, 40, from 35 you expect significant drop every year. 40 steeps down. 45, the chance of having a live birth, even in IVF, is 1%. So I would imagine by the age of 30, if you're going to postpone having kids, for whatever reason, I'm not promoting postponing kids and freezing eggs. Actually, I tell my patients, the better you have kids, it's better to have kids early in your life. And I think as a society, we should support young families to have kids early in life by providing them social and financial and all sorts of support. But by the age, people are different and circumstances are different. So by the age of 30, if you say, I want to do whatever, PhD and travel America and travel the world and blah, 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 and it will take me 7 years to do that, and then I'll settle and have kids, you better do something then. Freeze eggs or embryos if you are married or in a relationship. I think after 35 years, you expect that significant drop. I don't think at 35 years, you should do your ovarian reserve to see whether we can leave it for another 3-4 years or not. If you do it to see whether you need to do something now, and I guess at the age of 35, you should do something now. You shouldn't really postpone things. And as I said, you either get on with starting your family, or if not, you can freeze eggs or freeze embryos.
Thank you, Dr. Gorgy. We'll have
Thank
to
you.
leave it there. Thanks so much for your time today.
Thank you.